Let's talk about tardive dyskinesia. So this is a hyperkinetic movement disorder, and it's caused by dopamine receptor blocking agents. So different agents can cause the disease at different rates. In particular, the first generation antipsychotics are particularly prone to causing tardive dyskinesia, and about half the patients develop the tardive dyskinesias after 10 years of continuous medication treatment. Paradoxically, these symptoms can also be unmasked after a dose reduction, and this is thought to be because the medications as a side effect can also cause hypokinesis or Parkinsonism, and reducing the dosage can unmask the hyperkinetic movement disorder. Older age is a big risk factor for the disease, and the incidence is 3 times higher for people over the age of 55 years old. The mechanism is not completely understood, but it's thought to be due to specifically D2 receptor blocking and less so D1 receptor blocking. In terms of medications that cause tardive dyskinesias, the first generation antipsychotics are a big one. They can cause the disease at about 5 to 6% per year of treatment. And the second generation antipsychotics have a little bit less risk, but still about 4 to 5% per year. In terms of antiemetics, the metoclopramide is a big cause, and there's a particular recommendation that it should not be used for longer than 3 months continuously. Also, other antiemetics that have dopamine receptor blocking properties include prochlorperazine and chlorpromazine. In terms of a diagnosis, it's a clinical diagnosis. It usually appears after at least 1 month of treatment, but it can also be after treatment is stopped, and it can appear within the first 6 months of discontinuing an agent. If it appears after 6 months, consider a different diagnosis. In terms of the symptoms, you can have facial symptoms or orobuccolingual symptoms, and that can include tongue protrusion, lip smacking, and forceful blinking or blepharospasm. You can also have truncal or limb dyskinesias, such as shoulder shrugging, rocking torso movements, or twisting finger movements. You can also have dystonias, such as retrocollis or torticollis, and akathisias, which is basically motor restlessness. It can look like someone crossing their legs a lot or just tapping their feet a lot. You can also have chorea athetosis, which looks like dancing movements of the limbs. So otherwise, when you encounter someone with what you think is tardive dyskinesia, you'll want to take a complete medication history, in particular focusing on the dopamine receptor blocking agents, and you'll also want to rule out secondary causes of symptoms such as this. For example, you can have Wilson's disease. If you have any impaired liver function, you can consider that diagnosis. And thyroid function tests can be useful if you think they have thyroid disease. A MRI is not required for the diagnosis. However, if you think that the patient has like dementia or neurodegenerative disease, or maybe a structural cause with more focal symptoms, then you can also consider the MRI. In terms of treatment, prevention is the key, and anytime someone comes in and is on these medications, you'll want to consider, do they need to be on the medications? Can they be stopped or tapered down? When you think that someone does have tardive dyskinesia, the treatment is to taper or discontinue the dopamine receptor blocking agents. Sometimes you don't want to abruptly discontinue the agent. In terms of antipsychotic treatment, if they have to stay on an antipsychotic, quetiapine or clozapine can be good options because they're less associated with tardive dyskinesia. And not all symptoms have to be treated. For example, if they're not disabling or don't cause much social embarrassment, you can consider not treating with any additional medications. However, if the patient does desire treatment, you can give clonazepam or a VMAT2 inhibitor such as tetrabenazine or valbenazine. For refractory cases, you can consider deep brain stimulation of the globus pallidus interna. In terms of prognosis, the tardive dyskinesias usually persist for at least a month after discontinuation, and they may take years to remit. Particularly in older patients, the symptoms may not remit and may be lifelong.